Hi, my name is Lauren Giacobbe, and I am a perinatologist at the High Risk Pregnancy Center in Las Vegas, Nevada. I was asked to talk today about 17-hydroxyprogesterone and the use of 17-hydroxyprogesterone for prevention of recurrent preterm birth. So I'll be talking about the good, the bad, and the ugly of this medication. So the presentation today is on behalf of Nevada's Infant Mortality Collaborative Improvement and Innovation Network. I don't have anything to disclose today. And I'll just review the objectives. So I'm going to review the importance of preterm birth prevention, discuss the background of and indications for 17-hydroxyprogesterone, discuss the controversies regarding 17-hydroxyprogesterone, consider which patients are candidates for the medication, present barriers to receiving the medication, and then identify solutions to increase patient attainment of 17-hydroxyprogesterone. So just a brief review on preterm birth. So preterm birth is defined as birth between 20 and 0.7 and 36 and 6/7 weeks gestation. Premature birth and its complications are the largest contributor to death in the first year of life in the United States and the leading cause of death of children under the age of 5 worldwide. Morbidities include, but are not limited to, many of these acronyms that we're familiar with. So respiratory distress syndrome, bronchopulmonary dysplasia, intraventricular hemorrhage, necrotizing enterocolitis, sepsis, and then long-term chronic lung disease, cerebral palsy, and reduced cognition. So unfortunately, the US preterm birth rate increased again in 2017, and this was the third year in a row, although there was progress in some states. So the preterm birth rate in 2016 was 9.85%, and in 2017 was 9.93%. So this is from the March of Dimes. They put out this premature birth report card every year, and this is the one from 2018. So this includes the numbers from 2017. So if you look here, the grade for the national preterm birth rate is a C at 9.9%. And then we look over at Nevada, and unfortunately we got a D, which is 10.4 to 11.4%. Vermont is the only state here that got a grade of an A, which is 8.1% or less. Okay, so there are multiple, often complex causes and contributors to preterm birth: assisted reproductive technology related multiple gestations, older mothers with underlying health conditions, smoking, cervical shortening, asymptomatic bacteriuria, prior spontaneous preterm birth, and then, of course, chronic inequities and unequal access to quality health care, which is, of course, a more complex issue. So what I'll be focusing on today is the risk factor of prior spontaneous preterm birth, and then the use of 17-hydroxyprogesterone to prevent recurrent spontaneous preterm birth. So the association between progesterone and uterine quiescence was first described in 1954. And the two most likely mechanisms by which progestogens, and progestrogens just being any type of progesterone, prevent preterm birth is one, the anti-inflammatory effects that counteract the inflammatory process or processes that lead to preterm birth, and then also the local increase in progesterone in gestational tissues that counteract the functional decrease in progesterone that can lead to preterm birth. So there have been several randomized controlled trials that were conducted between 2003 and 2011 investigating the use of progestogens for prevention of preterm birth. So the question is, how do we utilize all of this data for clinical practice? So I'll start with the good, and I put good-ish just because there have been some issues with this study. But prior to this study, there was conflicting data regarding the efficacy of progestogens to prevent preterm birth. And this really is the study that established the use of 17-hydroxyprogesterone for prevention of recurrent preterm birth in the United States. So this was a double-blind, placebo-controlled trial involving women with a history of spontaneous preterm delivery. Patients were enrolled between 16 to 20 weeks of gestation and randomly assigned in a 2-to-1 ratio to receive either weekly injections of 17-hydroxyprogesterone or an inert oil placebo. So injections were continued until delivery or until 36 weeks gestation, and the primary outcome was preterm delivery before 37 weeks of gestation. So the results were that in women with a history of spontaneous preterm birth of a singleton infant, 17-hydroxyprogesterone decreased the risk of subsequent spontaneous preterm birth by 34%. The recurrent preterm birth rate was almost 55% in the control group and 36% in the progesterone group. There were also significant reductions in infant complications noted in the 17-hydroxyprogesterone group. And then I just put the results here in a table. So if you look, the outcomes here in red are the ones that were significant. So preterm birth less than 37 weeks. Here's the progesterone group here at 36.6%, and the placebo group at almost 55%. Then when you look at the odds ratio, so this was significant. And then any type of intraventricular hemorrhage, so 1.3% in the progesterone group and 5.2% in the placebo group. So several concerns have been raised about this trial, and the major concern was the high rate of recurrent preterm delivery in the control group, which, as I mentioned, was about 55%. So there, when you look closer, there was asymmetry in the risk of recurrent preterm birth in the two groups. So 41% of women in the control group had at least 2 previous preterm births, whereas only 28% of women in the progesterone group had at least 2 or more preterm births, and that was statistically significant. So that's important because the more preterm births a woman has had, the higher the risk of having another preterm birth. So the control group already was at a higher risk for recurrent preterm birth. So that's the argument. Another concern is that castor oil was the vehicle used in the placebo and the 17-hydroxyprogesterone injections. And there has been some evidence, some data that castor oil can stimulate uterine activity. The authors of the trial said that the amount of the castor oil used would not have been expected to cause any type of uterine activity. But again, it's the evidence and the data is not clear. So the last concern was that the trial was completed in 2 phases. So there was an initial 150 patients not included in the analysis due to concerns initially regarding the manufacturing of the 17-hydroxyprogesterone. So when you look at the rate of recurrence in the control group in the first phase, it was actually 36%, which was equivalent to the 17-hydroxyprogesterone treated group, meaning that you would not, if you had included these patients, not have seen a difference in outcome. So this is a study from AJOG in 2017, and this was a prospective cohort study that was showing that 17-hydroxyprogesterone actually did not reduce the rate of recurrent preterm birth. So I'm really presenting this information because although the recommendation currently is to give 17-hydroxyprogesterone in women with a history of preterm birth, there is more data emerging, and so the recommendations could change in the future. So then the bad about 17-hydroxyprogesterone. So as I mentioned, the etiologies of preterm birth are numerous and they're often nebulous. 17-hydroxyprogesterone is typically not advised in multiple gestations, which we all know is a group at high risk for preterm delivery. Optimally, 17-hydroxyprogesterone should be initiated between 16 to 20 weeks of gestation and really as close to 16 weeks as possible. So this really gives you a small window of time to begin the medication. Benefit has been demonstrated in some studies when progesterone has been started as late as 27 weeks, but insurance companies are not going to cover that. Lastly, there is some evidence that if you discontinue 17-hydroxyprogesterone early, then the incidence of preterm birth then increases. So if a woman decides to start it and has 3 injections and then stops, that she would increase her risk of preterm birth at that time. Okay, and then the ugly. So there are different formulations of 17-hydroxyprogesterone. There is the brand name McKenna, and that's an intramuscular injection. And then there's also a generic intramuscular injection. McKenna also recently came out with this subcutaneous auto-injector that is also another option. So 3 different options to choose from. Insurance companies often dictate which formulation you can give the patient, so that's another issue. Insurance companies as well dictate how long it takes. Some of them require pre-authorization. Some of them will cover a nurse or home health to give the injection to the patient. Others will not. So the insurance companies really, it can be difficult. And it can take quite a bit of time to get the whole process started and completed so the patient gets her medication. Common side effects would be injection site pain. So it is actually much higher with the auto injector. So it's definitely something you want to let the patients know about. Injection site swelling or a nodule. There can be pruritus at the injection site or just in general. Also urticaria and nausea and vomiting. I would say the most common side effect, though, is just the injection site pain. So it's also important to make sure that your patient does not have any contraindication to 17-hydroxyprogesterone. So you want to make sure they don't have a current or history of thrombosis or thromboembolic disease, a known suspected or history of breast cancer or any other hormone-sensitive cancer, undiagnosed abnormal vaginal bleeding unrelated to pregnancy, which could possibly indicate a cervical or uterine cancer, cholestasis of pregnancy, liver tumors or active liver disease, or uncontrolled hypertension. So despite all of this, the recommendation, and this is an SMFM statement from March of 2017, and so the recommendation with progesterone was reaffirmed. So SMFM states that in singleton gestations with prior spontaneous preterm birth, 20 to 36 and 6/7 weeks, 17-hydroxyprogesterone 250 milligrams IM weekly, preferably starting at 16 to 20 weeks of gestation until 36 weeks of gestation is recommended. And vaginal progesterone is not an appropriate alternative. So there have been multiple randomized controlled trials that have been unable to demonstrate benefit of vaginal progesterone in decreasing recurrent preterm birth in women with a history of preterm birth. So in somebody who says she doesn't want to have the injections, you don't want to offer vaginal progesterone as an alternative. Vaginal progesterone has been shown to be useful in women who do not have a history of preterm birth, but do have current cervical shortening. So that can be utilized. Vaginal progesterone can be utilized in that situation. So there are barriers to receiving 17-hydroxyprogesterone, and we see these a lot I see these a lot in my practice. So late prenatal care. If somebody has a history of preterm delivery and you're not seeing them until the second trimester after 22 weeks gestation, you are kind of out of the window of time to give them this treatment. And although there has been some evidence that it could be efficacious after 20 or 22 weeks, insurance is typically not going to cover that. There's also lack of screening by the OB office, so perhaps they're not asking the right questions or not getting the history of preterm birth early enough, and then you have missed that window of time to give them the progesterone. And then this sort of goes along with the lack of screening, is just failure to initiate the process early. So you might see the patient in the first trimester and know they have a history of preterm birth, but possibly not start the process early enough, and then again miss that window of time. So it can take 1 to 3 weeks, depending on the insurance, to complete the process of pre-authorization, obtaining the medication, and arranging for administration. So here are some ways to increase attainment of 17-hydroxyprogesterone. So this is a preterm birth checklist that my practice had put together and distributed to the OBs to assist with screening their patients for possible 17-hydroxyprogesterone therapy. So the first question here just states, is there previous history of preterm delivery from 20 to 36 and 6/7 weeks gestation? If they answer yes or correct, then they go on and answer the rest of these questions. If they say no, then of course they're not a candidate. And then the questions here are just if the previous preterm delivery was from spontaneous labor or PPROM, whether it was a singleton gestation, whether the current pregnancy is a singleton, and then it goes through those contraindications that we mentioned. So this is kind of a quick way to screen patients. I would say that you do want to follow up, though, with other questions. So I think it's important to list all of the pregnancies. So somebody can have a history of preterm delivery, but it's important to have the order of those preterm deliveries. So, for example, if a patient had a preterm delivery followed by a term delivery or 2 term deliveries, and they did not receive progesterone in those subsequent pregnancies, that patient is at less risk to have a subsequent preterm delivery than if the preterm delivery was the most recent. So it's important to have the order of the deliveries. It's also important, I think, to ask the patients the gestational age at delivery and include birth weight and time that the baby spent in the NICU. So you might ask a patient when she delivered and she might say, 7 months, 7 or 8 months. And you're thinking, well, maybe that's 28 to 32 weeks. Many patients don't refer to weeks of pregnancy, they refer to months of pregnancy. So sometimes it's a little bit difficult to determine when they actually delivered. So if you follow up and say, well, how much did the baby weigh? How much time did the baby spend in the NICU? And they say, yeah, I delivered at 7 months. The baby weighed 6.5 pounds and went home with me. Well, then that doesn't quite go along with a 28 or 32 week delivery. So you can get a little bit more information if you just dig a little bit. And then I also think making sure you're asking specifically complications of each pregnancy and not just saying, well, did you have any complications, but asking, was there bleeding? Did you have preeclampsia? I'll often see patients who come in and the referral says history of preterm delivery. But when I ask them, they say, well, they induced me. They said my blood pressure was high and I needed to deliver. So an indicated preterm delivery is obviously not going to be an indication to receive 17-hydroxyprogesterone. So starting early is also key. So once it is known that a patient's a candidate for 17-hydroxyprogesterone, you really want to start the process of obtaining the medication. And lastly, we have in our office a coordinator for 17-hydroxyprogesterone. So she is assigned all of the management and it works really well. So that person coordinates the receipt and administration of progesterone with the patient, the insurance company, and home health. So I think it helps so that some of the details don't fall through the cracks and there is one contact person. So I wanted to just go through some cases just to illustrate what we have talked about here. So let's take case 1. So this is a 28-year-old G2 P0102. She's at 12 and 5/7 weeks gestation. And her prior pregnancy was a vaginal delivery of twins at 32 weeks gestation. So do you offer her 17-hydroxyprogesterone? So I put maybe. And the reason it's maybe is because you could offer her 17-hydroxyprogesterone based on expert opinion, but there really is insufficient evidence to strongly recommend it. And in addition, insurance is, I haven't had any insurance companies cover that when the history is a twin delivery. So case 2, we'll just reverse it. So a 28-year-old G2 P0101 at 12 and 5/7 weeks gestation, and her current pregnancy is twins, and her prior pregnancy was a vaginal delivery of a singleton at 32 weeks gestation. So then do you offer her 17-hydroxyprogesterone? Okay, again, maybe, right? So you can offer it based on expert opinion, but there's really not a lot of data to strongly recommend it. And insurance companies, again, are not going to cover this. Okay, so case 3, 28-year-old, G2P0101, 12 and 5/7 weeks gestation. So kind of the same patient here. And her prior pregnancy was a vaginal delivery of a singleton at 32 weeks gestation. So is this a candidate, is she a candidate for 17-hydroxyprogesterone? Okay, and I promise I will have answers other than maybe, but my maybe here is because first you need to get a detailed history. So we will do 3A. Let's say that her history is my water broke at 31 weeks, then I went into labor at 32 weeks. So is she a candidate? And the answer is not maybe. So yes, she is a candidate. So that's classic spontaneous preterm delivery, PPROM. This is somebody that you would talk to about progesterone, talking to her about the risks and benefits, making sure she doesn't have any contraindications, and getting started early to get this for her. All right, let's say instead she gives her history as I was 3 centimeters dilated at 32 weeks. They gave me a shot in steroids, but they couldn't stop my labor. I delivered the next day. So is she a candidate for 17-hydroxyprogesterone? And she also is. So again, classic preterm delivery. So again, you go through the same thing with her, risks and benefits, and making sure that she does not have any contraindications. And I just added this because often it's not clear cut. Often other things are happening, right? So let's say you did offer her the progesterone, and let's say she started it at 16 weeks. And then she comes in, because with a history of preterm delivery, you are still going to be wanting to monitor her cervical length. So let's say she comes in at 20 weeks and her cervix shortens to 9 millimeters. So then what do you do now? Do you keep giving the progesterone, the 17-hydroxyprogesterone? Do you switch it to vaginal progesterone, or do you add vaginal progesterone? Maybe you put in a cerclage. So these are all the options. So I'll let you think for a minute. Oh, sorry. So you would continue the 17-hydroxyprogesterone and then offer her a cerclage. There is limited data suggesting, or there's limited data to really know whether adding vaginal progesterone is useful or not. Some people will do it, but this is somebody who you should talk to about a cerclage, because if you look at outcomes of people in this situation, whether they're given a cerclage or not given a cerclage, the ones who receive cerclage have significantly better outcomes. Okay, another history, same patient with case 3C. So let's say instead she gives you this history. She says, I had bleeding off and on the whole pregnancy. I started bleeding and contracting at 32 weeks and they delivered me. So do you offer her 17-hydroxyprogesterone? And I put probably not, because this seems to be more of an indicated preterm delivery. It sounds more like a chronic placental abruption. So, you know, you could make a case for this, but this is not somebody who I would strongly recommend 17-hydroxyprogesterone for. So case 4, last case, this is a 28-year-old G1 with cervical length measuring 1.7 centimeters at 18 and 1/7 weeks gestation. So do you offer her 17-hydroxyprogesterone? And the answer is no. So we, you know, as I mentioned earlier, so this is her first pregnancy. So you do not offer 17-hydroxyprogesterone to somebody who does not have a history of preterm birth. This would be a patient that you would talk to about using vaginal progesterone. Okay, so conclusions. 17-hydroxyprogesterone is currently recommended in certain populations for prevention of recurrent preterm birth. It's It's important to take detailed histories to assure all eligible patients are counseled regarding the option of 17-hydroxyprogesterone. And I think a checklist can be useful for all new patients. And then specifically tasking one person with coordination of 17-hydroxyprogesterone also, I think, can be really useful to assure that the details are not being missed and that things are happening in an efficient way. So that is the end of my presentation. Thank you for your time, and I hope that this was useful.